Good afternoon, good evening to everybody. This is a presentation, but I will try to keep it quick. It's about an old new drug called Ziconotide, but please let me start with the very basics. What is neuromodulation? So if you visit the official website of the International Neuromodulation Society, you will find this definition there: the alteration of nerve activity through target delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurological sites in the body. There are many diseases that we can treat with neuromodulation. What is important for us today is pain. There's a huge list of operations that we could perform in the context of neuromodulation. One of them is this intrathecal drug delivery, the implantation of a catheter in the spinal canal, and the connection of this catheter to a medical pump. Chronic pain, it's not a new problem. It's a very old problem, as old as the humanity. And in all countries, I'm working in Germany, there are many magazines, there are many newspapers that are interested in this topic. And every month we are seeing articles about pain, acute pain or chronic pain. In everyday life, these are the patients that we're seeing, patients with trigeminal neuralgia or neuropathy, with different types of headaches, with radiculopathies, back pain, neck pain, arm pain, leg pain, phantom and stump pain, polyneuropathies, plexus lesions, angina pectoris, PVD, post-herpetic neuralgia, complex regional pain syndrome with or without capsalgia, and humor pain. The intrathecal therapy. I think most of you have heard of this World Health Organization ladder. We should start with non-opioids, then used the mild opioids, and then the strong opioids, and in the end of the whole therapeutic attempt is this intrathecal opioid or non-opioid therapy. But we have seen that if we start offering our patients other options, such as pulse radiofrequency, spinal cord stimulation, before even starting with opioids, then the results are much better. Let's consider now on the intrathecal therapy. The intrathecal therapy is working at the level of the second neuron. It's only a part of the whole interventional pain management. This is what we see in the operating room when we have a patient who have to have access to the abdomen to implant the pump, who have to have access to the lumbar spine to implant the catheter. We are using a needle to do the insertion of the catheter, and we are placing a catheter with a tip, a T4 to T8 using fluoroscopy. This is the gold standard, the pump that we are using now, a Synchromed pump. You can see there is a central septum where you can refill the pump. There is also a lateral septum where we can aspirate cerebrospinal fluid or give a bolus of drugs. This is how it looks in real life in the operating room, the pump in the pocket, in the abdominal area. This is what it looks after the operation of the catheter. You won't see it. This catheter is only the tip of it on X-ray visible, and this could cause some problems when we're talking with our radiologists. This is the history of the intrathecal therapy, the very first pumps that have been used for this intrathecal therapy. These are non-programmable pumps. There is a gas inside, and this is the new generation of pumps, the electronic or programmable pumps from Metra and Synchromed. If you're interested in such a pump, this is how it looks. If you could open it, the biggest part of it, it is the battery, of course, and this is how it looks like on an X-ray. A very interesting article, Polyangelic Consensus Conference, published in Neuromodulation, a journal with an impact factor of more than 4. Just to keep it short, if you have patients with cancer pain, you should start with the intrathecal therapy. If you have patients with non-cancer pain, you should always try with pulse radiofrequency or spinal cord stimulation, so with electrical impulses. A provocative question: if we are going to jail, why? Because the official allowed drugs for the pumps is baclofen for patients with spasticity and morphine and ziconotide for patients with chronic pain. No combination of these drugs is allowed officially, and this could lead to legal problems. And this is why it's important to speak about ziconotide. What is ziconotide? It is a peptide of 25 amino acids. It was originally isolated from the venom of the cone snail Conus magus as omega conotoxin, but now, of course, it's produced synthetically. If you're interested in the topic, I would advise you to download this article. It's for free. its review article, I think it's pretty good. The advantages of the drug. Let's start with the most important one. It's not an opioid, meaning does not cause any respiratory depression. We don't have tolerance. We don't have withdrawal symptoms, just in case we have to stop the therapy, and we don't have any endocrinologic abnormalities, problems that are really frequent when we are working with morphine. And this is an old video showing this cone snail, how it can immobilize the victim, the fetus, and kill it. And this animation showing the concept of this therapy. Without Ziconotide, in the primary afferent neurons, we have calcium channels. When calcium is coming in, the result is the release of neurotransmitters. And at the level of the dorsal horn, these transmitters are helping to transmit the pain signal to the brain. If we are using Ziconotide, the concept here is that Ziconotide can block these calcium channels in the primary afferent endings. And if these channels are blocked, then the calcium ions cannot enter. If we don't have any calcium ions, then we don't have any release of neurotransmitters, and we don't have transmission of pain to the brain. Ziconotide is a drug which we should use with caution. There is a principle here: start low, slow doses, and go slow. You should do the titration really slowly. Why? Because if you don't do it in such a way, you can have side effects: cognitive impairment, hallucinations, depression, suicide in susceptible patients, reduced level of consciousness. What we see frequently is an elevation of serum creatine kinase, but also dizziness, nausea, confusional states, nystagmus. It does take time to find the effective dose, and this should be communicated before even starting with this therapy. As with all drugs, the temperature, the altitude, and the light influence the stability of Ziconotide. The pumps must be refilled every 4 weeks because Ziconotide is diluted with natrium chloride in the pump. And although dilution is essential during testing, we have a degradation of the Ziconotide when the Ziconotide is in the pump. We should always keep that in mind. Based on the publication that I mentioned earlier, we have some requirements. We can use an internal or external pump to deliver the drug for cancer patients or for non-cancer patients. The parameters of success is the pain relief, the adverse effects, if we have adverse effects or not, for example, psychosis or hallucinations. And if the initiation of the drug is successful, then we can implant a permanent pump. Always keep in mind, we need a neuropsychological review of the patient. We always need to check regularly the creatine kinase levels. We should always check the dose in regular intervals, and we need these patient-reported outcomes. It's not about only pain severity, it's about quality of lives. Now we suggest that we should start with a small doses of 0.6 microgram per day and increase the dose once till twice per week maximum. For non-cancer pain, we have a maximum dose of 19 micrograms. If you need more than 19 micrograms, then the patient is not going to benefit from the drug. For cancer pain, there is no maximum dose. And this is our work published or presented in the World Congress in Barcelona this May 2022. It's only 6 patients with failed back surgery syndrome or persistent spinal pain syndrome, if you want, and 1 patient with multifocal pain. You see the pain starts from 8.5 and in the end it's 5.7. So here we're talking about pain relief of 20 to 40%, not more, but these are the really difficult patients that are not respond to morphine or to other drugs. In the future, we should see what happens if we are using a combination of drugs in the pub. Is it safe? Is it efficient? We should talk about the switch protocols from opioids to Ziconotide, about the titration strategies, about the optimum level of the catheter placement, and as I mentioned, we need not only the pain scores, but also the quality of life in such patients. The take-home message: we should share our clinical experience. The drug is in the market since 2004, but the titration back then was completely wrong. This is why the results back then were problematic. This is why it's really important to speak about our experience about our everyday practice and see what we did wrong back then and what should be done now. Ziconotide is an effective alternative to morphine with good long-term safety and tolerability, and extends our choices in the type of the global opioid epidemic, especially in the United States of America. Thank you very much for your time.